नदीम सर 7:30
Yes.
हो गया.
हाँ जी.
नहीं वो शुरू करें क्या अभी नदीम सर?
Oh yes.
नदीम सर कहाँ चले गए?
मैं अपने आप को म्यूट करूं क्या?
नहीं नहीं सर कोई बात नहीं. तो ज्यादा लोग भी आए नहीं शायद.
हाँ, तो आप कहाँ बेस्ड हो?
सर मैं कलकत्ता में बेस्ड. आई मीन मेडिकल कॉलेज, कोलकाता मेडिकल कॉलेज.
Oh great.
हाय
मैं
नीरज.
बहुत जूनियर हूँ सर, मुझे आप मत बोलिए.
नीरज दमेशा भी आ गया.
Oh wow. Oh, अच्छा हाँ वो तो BHU में है ना?
Correct.
Yeah, no.
So we'll be starting.
Sure.
Okay sir.
So Dr. Rajeev, if you can stop sharing, then I can share my screen.
Sure. I have stopped.
Yeah.
Okay.
Good evening, everybody. Welcome to this evening episode of Pursue, and this is Pursue 60, Liver and GI, and we are streaming live from Liverpool, UK via Kolkata. And today we have a very special person, Dr. Rajeev Shukla, and he will be talking on a very special topic. But before I introduce Dr. Rajeev Shukla, let me introduce the moderator, Dr. Tuhin Pal, who's a postgraduate from PGI Chandigarh. He's an assistant professor in oncopathology in the Medical College, Kolkata, India. He's a visiting consultant at the famous Ruby General Hospital with several publications in national and international journals. I would ask Dr. Pal to take over and introduce the speaker and to conduct this entire program. Thank you so much, Dr. Tuhin. Please take over and please start.
Thank you, sir. I have to share my screen or?
No, you can just go on, no problem.
Okay. Good evening, ladies and gentlemen, and thank you, Nadeem sir, once again. I am joining you from Kolkata on a very chilly evening, a December evening, and I'm delighted to introduce to you today's speaker, who happens to be from Liverpool, which is, I believe, an even chillier Liverpool right now. So the temperature is far lower than Calcutta, at least. Now, before I introduce the speaker, I would like to add that apart from the Pursue series and the football, obviously, that connects Kolkata and Liverpool, I found there is one more thing that connects these two famous cities, and that is, believe it or not, the humble Anopheles mosquito and Sir Ronald Ross. I didn't know it, so I dug it up from Wikipedia, and I found that Sir Ross, after his famous experiments and publications from IPGMR Kolkata, went back to England and he joined the Liverpool Tropical School of Medicine. I knew of the London Tropical School of Medicine and didn't know that Liverpool also had. Apparently, it's also a very famous institute. And he completed his research on malaria and subsequently got the Nobel Prize at Liverpool while he was in Liverpool in 1902. So that is another unique connect between Calcutta and Liverpool. So now, Dr. Rajeev Shukla needs no more introduction. He's a fellow PGI senior and he's a world expert, as everybody knows, on pediatric pathology. And he will be speaking on a very important, but I believe often neglected topic, at least in India, which is the pathology of Hirschsprung and allied disorders, the key practice points. So without much delay, I will just add a line by Benjamin Franklin, and I quote, "Tell me and I forget, teach me and I remember, involve me and I learn." So come on, ladies and gentlemen, let's all get involved and try to learn something from this academic piece. Over to you, Rajeev sir.
Brilliant. Thank you, Tin. Thanks a lot. And yes, you're right. The Liverpool Tropical Institute of Medicine is really famous, and they're doing really good work. I just
Just present now and share your screen.
is this the right screen?
Yeah, absolutely right. That's
Yes,
it.
sir. Yes, sir.
And is moved to new screen now?
Yeah. Yes.
Yes. Okay. So now I'm going to talk about Hirschsprung's disease, mainly about it, and then some related disorders. And Hell Hirschsprung was a Danish pediatrician, and his dad had a tobacco factory, and he could have well become a tobacco kind of. Followed his dad's footstep and become an owner of tobacco factory, but he instead chose to become a pediatrician and went on to describe Hirschsprung's disease. And one anecdote which is famous for him is that he used to teach, and he wanted only deserving and kind of dedicated students to come to his kind of teaching sessions. So he will do it deliberately on Sundays and odd hours. And I've seen Dr. Nadeem also organizes this particular session at odd times, either is on weekend or late in the evening when people have some better things to do probably. So I'm very sure whoever's here is dedicated, and I've got a very dedicated audience here. What I plan to do is I just want to discuss the pathophysiology, then biopsy diagnosis of Hirschsprung's disease, and then discuss how pathologists help in actual treatment of this disorder. And what you're seeing on screen is a segment of intestine which has been separated from the body. Obviously, it's in a pool of water, and no connection with spinal cord, no connection with brain, but it's still functioning, and it's a really complex function. And these kind of studies were done very early on, and Bayliss and Sterling published about the law of intestine, which basically says that if you distend an abdomen by in this case is as a kind of palate, there'll be contraction at the back of it so that it can push it, and there's a relaxation in front of it so that it kind of receives the fecal matter in that sense. And this is possible because of what we call as brain in the gut, or the enteric nervous system. And it is pretty complex system, and you won't believe, but it has got more neurons. The gut has got more neurons than the whole of the spinal cord. It's got more than 20 different types of neurons, probably more. And almost every known neurotransmitter which is known in brain is also found in gut. In fact, a couple of them extra. And nearly more than 50 to 60% of dopamine and serotonin is produced in the gut. So it is pretty complex. And the reason I'm telling you this is that we know how we are describing Hirschsprung's disease, but there are many other disorders of motility in children, and so that's why we have to keep which we don't know much about. And again, this is one of the kind of reflex system which I was talking about for peristalsis. So there are different types of neurons. Once there is distension, there are afferent neurons which take up the signal to interneurons. And there are two types of interneurons, one going up. Up means to the more proximally on this side, where they attach to the motor neurons which are excitatory. So they'll secrete acetylcholine and substance P. So this will cause contraction of the circular muscle layer. Whereas the one which is going down towards more distally, they connect into inhibitory motor neurons, and they secrete nitric oxide, VIP, and other things. So, and this causes relaxation, and this has to be there for peristalsis to happen. And I was talking about how many neurotransmitters are there, how many different types of neurons, and then this is not an exhaustive list, by the way. And embryologically, the enteric nervous system comes from neural crest, and mainly the neural crest in the region of where the vagal system comes from. And the neurons migrate proximal to distal, so they start somewhere around oral cavity, esophagus, and go down and right to the anus, right to the distalmost part of the rectum. What happens? There is intrinsic system, which is enteric nervous, but there is a control in the bowel from extrinsic kind of control, which is mainly by parasympathetic innervation, and that is sympathetic innervation as well. What happens in Hirschsprung's disease? There is migratory arrest. So the neural crest cells start migrating, but arrest at some level. It could be anywhere. It could be very near to the anus, a very short segment, or it could be right up in cecum, anywhere. So once this happens, there is another interesting thing happening, which is again very important in the pathogenesis and when we diagnose cases. The parasympathetic hyperplasia occurs. So the parasympathetic system nerve fibers, they are kind of opportunists. So in a sense that if there is no enteric nervous system there, they will put their nerve, the parasympathetic nerve hyperplasia occurs. So these are the two cardinal features of classical Hirschsprung's disease. There is absence of ganglion cells in the distal mode part, and then there is parasympathetic hyperplasia as well. And what happens because of that, this segment, the distalmost segment, fails to relax. And obviously then there is obstruction. This is functional obstruction, and everything else is all secondary. Now, as I said, that for intestinal motility, there are a lot of other players also. You need to have a proper functioning smooth muscle. So you can have a myopathy of some sort can give a similar dysmotility, although a bit different, but dysmotility. Enteric neurons are supported by enteric glial cells, and the reason I'm saying glial cells, not the Schwann cells, because the supporting cells in intestine, enteric nervous system, are very similar to the glial cells in brain rather than the peripheral nervous system Schwann cells. And then there is a pacemaker of intestine. So you could have abnormality of any of these to lead to intestinal dysmotility, and that's why there's a whole list of kind of differential diagnosis of intestinal motility disorders. And again, I'm emphasizing the fact that based on what I've told you, the classical Hirschsprung's disease, the obligate feature is absence of ganglion cells in the terminal most part of the rectum. So if you have hypoganglionosis, which is not actually absence but the reduced density, it has got different pathogenesis and it's not Hirschsprung's. Similarly, segmental ganglionosis, where the distalmost part has got normal ganglion cells, and somewhere in the skip and somewhere else in the colon there is aganglionosis. That also has got different pathogenesis, different management, different genetics probably. So, and then there is a host of disorders called intestinal neuronal dysplasias, where actually ganglion cells are present, but there's some other abnormality there, and those are not considered Hirschsprung's disease because they're going to not be managed by surgical management most often, so they can be treated medically with variable success, obviously. Obviously, then another thing which helps is what I told you is parasympathetic hyperplasia, where and evidence of extrinsic nervous system getting more expressed in those part of the system. And we will use these two things to diagnose Hirschsprung's disease. And one thing I want to say here, the obligate feature is absence of ganglion cells. So the moment you see ganglion cells in what appears to be a terminal most part of the rectum, if the biopsy is from the right area, the Hirschsprung's disease, classical Hirschsprung's disease, is excluded. Parasympathetic hyperplasia may or may not be present, as you come to see when you go in the presentation later on. The clinical presentation most often is in the neonatal period, and the classical thing is lack of passage of meconium in the first 24 to 48 hours. And these children, so it is a very important disease, as rightly pointed by Tuhin. This is a fatal disease, so a cancer will kill in months. This disease kills in days if not treated, and especially the one I'm talking about, the neonatal presentation. So if not picked up, not treated, these children will develop abdominal distension, vomiting, and most importantly, what is called as Hirschsprung's enterocolitis, and it is rapidly fatal. So it is important that all children who don't pass meconium is first to 24 to 48 hours should be at least try to exclude Hirschsprung's disease. And there are some other presentations. So I would say 80 to 90% of cases will present like this, and the remaining smaller proportion presents a late presentation where there'll be constipation, which is severe and variable, and some will have recurrent enterocolitis as well. So this is a plain X-ray and an infant who was presented typically with the kind of presentation I've just described, that lack of passage of meconium and abdominal distension, and what you see is just distended bowel. And one thing is that always our radiologists say that you can't distinguish small bowel distension from large bowel in cases of infants, so don't try to do that. And if you see this, you go on to do a barium enema, and that shows a much classical picture if present. And what it shows is that the distal most part is the aganglionic narrow rectum. Then there is a kind of funnel-shaped transition zone, and then it ends into which is actually a normal part, which is the dilated ganglionic segment. Unfortunately, this picture is not present in many of the cases, and particularly the ones when you do it early. So if you let them live, kind of, if you do these kind of studies later on, when dilatation has started developing much more prominent, you'll see this. Otherwise, in many cases, it's not typical, and the only way to confidently diagnose, even if this picture is present, is by biopsying. That's another subset of cases, which is an example of a total colonic agangliosis where everything is narrow, that there's no dilated segment at all. Now, based on where the arrest has happened, how much length of the bowel is aganglionic, you could classify them into ultra short, short segment, long segment, total colonic aganglionosis. The commonest and what we call as the classical Hirschsprung's disease is the rectosigmoid. So only this part up to the sigmoid colon is affected, and around 80%, or so 8 out of 10 cases would be like this. And this is the one which will have the more classical histopathology as well. The other cases may have some atypical features, and same is true with ultra short segment Hirschsprung's disease as well. Now, so that's like these two diseases probably are different. The one which you call as the classical Hirschsprung's disease and the long segment Hirschsprung's disease, or total colonic including one. And so if you see the classical Hirschsprung's disease is distinctly common in males, so it is almost 5 to 6 times more common in males than in females, whereas there's no gender bias when you look the long segment disease. This one tend to have a multifactorial, the classical ones, inheritance and recessiveness, so it's less likely to have a family family member affected. However, the long segment or all the colonic ones tend to have a dominant inheritance, so you're more likely to have a family member affected, and it's so high recurrence rate in that sense. It is, as I told, is Hirschsprung disease is a multigenic disorder, and around 70% of cases of are non-syndromic, so they will not have any other abnormality, nor they'll be associated with karyotypic abnormalities. So these are called the non-syndromic isolated ganglionosis. It is common. In general, in Hirschsprung, RET mutations are the commonest ones, and the lot of other genes which are basically downstream of RET pathway, so which are important for enteric nervous system development are involved. And if you see the commonest mutation of basically is a single nucleotide polymorphism in the isolated ones and the non-syndromic ones, and it occurs in the non-coding regulatory gene. The coding gene mutations are more common in the familial ones or the long segment disease. As I said, none of these are important for diagnosis, so probably I'll not dwell too much on it. But one thing, if you want to see whether we should be doing genetic tests in your cases, I would say if it is syndromic, obviously you want to know what syndrome it is, and that will dictate what side of genetic counseling you'll do. In a non-syndromic cases, people have recommended that you could look for MEN2A and familial medullary tumor medullary carcinomas of thyroid thing, and the whole reason is because they share the same genetics, and a very small proportion of Hirschsprung disease are predisposed to this. We don't do regularly unless there's a family history, so the syndromic ones we refer to our genetics team and they will work it up. Non-syndromic ones, if there is a family history, probably we would do something like that. So, as I said, Hirschsprung disease is absence of enteric nervous system, and the enteric nervous system resides in what we see as a submucosal plexus of neurons or ganglions, and the intramuscular plexus. So that's you've got a circular, outer longitudinal, and here and there. The good thing is, not good, but what helps is that when the migration occurs, it occurs simultaneously. So if there is a neurons present in the submucosa, it is present in the myenteric plexus as well. Although it is these myenteric plexus neurons which are important for kind of more motor functions and in Hirschsprung's, even if you biopsy a submucosa and demonstrate that ganglion cells are absent or present, you could kind of make a diagnosis or exclude Hirschsprung's disease. And this comes handy because in a neonate you don't want to subject them to anesthesia, and a submucosal kind of suction biopsies are relatively easy, and they can be done on a bedside, no need for theater time, and no need for anesthesia. And the way it works is that there's a suction device which is connected to it. It provides a suction, and there you trigger the blade and a cutting blade, and you get a biopsy. Now this is only done mostly in younger infants. I'm talking less than 6 months. In older children, you don't get adequate material, and this could be because of multiple reasons. Either there is a fibrosis develops, or edema, or whatever. But so for older children, you tend to have a kind of a biopsy which is bigger, or full thickness biopsy, or you use different techniques. The suction biopsies works well for neonates. And then where do you biopsy from? When I was talking about neuronal migration, all the neurons come right down to the anal mucosa. That's not a problem, right to the end of the rectum. However, the distalmost 1 centimeter is said to be hypoganglionic. And the most important thing we're looking for is presence of ganglion cells. And so if something is reduced, you may falsely call it absent, and are there. So the recommendation is that the best size of biopsy is around 2 centimeters from the we call it, in here it says dentate line, but our surgeon site is as good as saying it 2 to 3 centimeters from the anal verge. And if you biopsy too high, suppose you may miss a very short segment Hirschsprung disease. So suppose this particular segment is aganglionic, and you biopsy just above it and you see ganglion cell and says it's not Hirschsprung disease. So the site of biopsy is important, and to kind of circumvent this, what our surgeons do is they biopsy take 3 biopsies, one from 2 centimeter, 3 centimeter, 4 centimeter. So they covered everything. So that you just cannot say, oh, you've given me a too low biopsy or too high biopsy. You've got everything covered. And we always talk about adequacy of rectal biopsy for diagnosis of Hirschsprung. If ganglion cells are present, whatever it is, I say it is adequate, because that's the obligatory diagnostic feature, which is not there. If you should see ganglion cells. And just because we're looking for a negative finding, we need to have a certain size, and we say at least it should be 2 millimeter in diameter, the biopsy size, and it's the submucosa where the ganglion cells are there. So if you got loads of mucosa but very little submucosa, that is of no good. And so we say at least 1/3 of the biopsy should be made up of submucosa. And when we do serial sections to look for ganglion cells, we say at least 60 serial sections. I'll come to that number, how we come to that arbitrary 60 serials. And there should be no anal squamous mucosa or transient, and this will signify that it's a pretty low biopsy. Back to our old thing, so we're looking for absence of ganglion cells and evidence of abnormal parasympathetic innervation. Now, the most important thing is searching a ganglion cell is like a needle in a haystack, and you want to know how long you should be looking, how many sections you should be, because before telling something is not present. And on an average, ganglion cells are 500 microns apart, ganglions, and in a 3 millimeter biopsy, there's a lot of chance that in a lot of sections you may not see ganglion cells. And so it's important to do serial sections before you say that ganglion cells are not present. So, sorry. Yeah, and so we did an audit, and probably it's there very much experience with all others and other recommendations as well. And we found that in the 95% of our cases, we could find ganglion cells in first 36 serials, but to pick up another 5% of biopsies with ganglion cells, we have to go up till 60 serial section, and so that's what we follow now. But many other people say, even go on to say that 75. When in doubt, I say just run through the block and see as many. So we have cases where we have found we've done more than 200 sections, and probably it has helped in some way. So there's a frozen section where you can see ganglion cells. I'm not going to describe ganglion cells, most of you know. The thing is that when you have a neonate or a premature, the ganglion cells may be immature, so they will not have that cytoplasm, they may not have nuclear prominence, and that's why you may struggle in cases, and some of them you may mistake for endothelial cells, and other way around as well. So immature ganglion cells, you may stress. So difficult identifying them, and you should always be wary of certain pitfalls, and the commoner ones are plump endothelial and plump fibroblasts. Sometimes when you're not seeing mucosa, part of mucosa kind of crypt epithelial cells may be seen what appears to be under the muscularis mucosa and below the muscularis mucosa because of the orientation issues, and that's also possible not to fall in that trap. And occasionally we've seen a CMV mimicking like ganglion cells, CMV in the endothelial cells. Other extreme is where cells are ganglion cells, they don't look like one, and these are the morphologically immature ganglion cells. With experience, you'll start picking them up, and usually it's when it's present, it's not going to be a problem. If you're struggling, we can take help from IHC or enzyme histochemistry. That's the ganglion cell there. Some more ganglion cells. One thing which helps when you're in doubt, and if you start seeing nerve fibrils entering a structure which like ganglion cells, you're very sure that it is ganglion what you're looking at. That's one of the CMV, and this case came from outside, and this is at a very high magnification, but someone has looked at low power and called it as ganglion cells, and actually this was Hirschsprung's disease with CMV, and we de-stained it, and CMV immunohistochemistry was positive. Now, this picture was given by one of my colleague. In fact, he's one of my mentors here, and he came to my room and said, with the one hand on his eyes, and say, "I've dropped my eye on this. I've already seen 200 sections. I can't see anymore." So you have to see a lot of levels. So you know how to look for ganglion cells, but it may not be easy. You have to do a lot of serial sections, so that's the key. Now, what is the evidence of hyperplastic kind of or hypertrophic parasympathetic system? You start seeing thick nerves or hypertrophic nerves, and normally the nerves seen in, especially I'm talking about the infants, is rarely above 40 microns, and in this case you can see they are mostly above 40 microns. Obviously there are a couple of them here and there which are not. When you're measuring a nerve diameter, it's important to do it on a short axis. Otherwise, if you do it on a long axis, probably you caught a nerve in a longitudinal axis and it could be really long. So if you get it like these, if you start measuring the short axis, and so hypertrophic nerve fibers more than 40 microns in an infant is quite significant finding and indicative of Hirschsprung's disease. Another thing which happens, which is a different from intrinsic nervous system nerves, is that these nerves tend to be much more organized. This is the extrinsic nerve. The submucosal nerve for enteric nerve systems tend to be very loose and kind of irregular thing. Another important feature is you don't see this thick perineural cells. Can you see this? And if you stain with GLUT1, you can highlight the perineurium very easily, and this, you're sure that this hypertrophic nerve is extrinsic and this nerve, and there are no intrinsic nerve fibers. So you can, on morphology, figure out, looking at a nerve, even if it is not thick, that much thick, whether it is extrinsic or intrinsic. So this was the early papers where people started telling that a nerve hypertrophy of more than 40 microns is quite specific. It's seen in more than 90% of cases of Hirschsprung's disease, and none of the cases of non-Hirschsprung's cases. So it is an important thing. However, subsequently, it was seen that actually 1/3 of cases of Hirschsprung's disease may not show nerve hypertrophy, and this difference is because in this series, the first series which came in 1998, most of the cases were the classical Hirschsprung disease or the short segments Hirschsprung disease, where nerve hypertrophy is much more common. In this case, there were quite a few long segment disease as well, and many of them didn't show nerve hypertrophy. So that's one thing. Another interesting paper which came later on, and was that in older children, anyone more than a year, 40 micron nerves are quite common. This was based on autopsy data. So in older children, you may have a nerve which are more than 40 micron thick. So the diagnostic help. So if you're seeing nerve hypertrophy in an older child, don't jump to the diagnosis of Hirschsprung disease. So that's the key lesson I want to tell you. So if you're seeing more than 2 nerves and more than 40 microns thick in a one high power, probably you know that it is nerve hyperplasia, and it is a very good aid for diagnosis of Hirschsprung disease in children less than 6 months. Not so much reliable in older children. But remember, this is not essential, as a lot of cases of genuine Hirschsprung disease may not show nerve hyperplasia. What else you can do is, when there is parasympathetic hyperplasia, there are a lot of nerves from parasympathetic nerves which obviously mainly secrete acetylcholine, and then there is an enzyme acetylcholinesterase at the nervous junction. So if you stain acetylcholinesterase, you can look for parasympathetic. So they tend to be more in cases of Hirschsprung disease, and so that's how it sees. Normally, if you do ACHE, you will see fibers which are not very dense, so a few fibers scattered, and they're restricted to the inner half or 2/3 of the muscularis mucosa. So they don't go into the top part of the muscularis mucosa. The density is not that much, the fibers are not coarse, and they don't get into lamina propria. However, in Hirschsprung disease, these fibers are far too many. They span all throughout the thickness of muscularis mucosae and extend in the lamina propria. So that's abnormal. A couple of more examples: very thick coarse fibers, lot more than what you see normally, extending into lamina propria. The 2 patterns described, it's of no diagnostic significance other than I'm telling you that the type B pattern is far more common. And so the type A pattern was set to where it is the coarse fibers extend right throughout the lamina propria right to the top, whereas the type B pattern, it is restricted to muscularis mucosae. And it is the type B pattern is much more common in younger infants, and that's our experience, and that's because we get most of the biopsy in the first couple of weeks. We tend to see this pattern more, where the coarse, numerous fibers are restricted to muscularis mucosae and just the inner half of the lamina propria. Another common pattern which we see is what we call tram tracking, where instead of the fibers going vertically as in here, they extend in the lamina propria but restricted to the deeper third, and they go parallel to the muscularis mucosae. It doesn't matter, both patterns are diagnostic. The problem with ACHE is is it okay? Are you able to hear me? Okay. The problem with Hirschsprung for ACHE is it's not always diagnostic. There are a lot of equivocal results, and it needs a lot of experience before you start interpreting. So the extremes are fine when there is kind of known very minimal fibers in a normal versus very severe kind of hypertrophy, but somewhere in between it's really tricky, and it's you need a lot of experience there. There are papers which say that if in a 1 millimeter biopsy you can with the ACHE you can diagnose 90% of cases, but as I said, a lot of cases will not have ACHE abnormalities early on, especially in the premature infants, and so it's not that sensitive. You can see false positive results which are unusual, and it is mainly due to inexperience with the techniques. Sometimes in a hemorrhagic specimens you tend to see more stronger staining, and then in that case you mistake it. Colitis, somehow inflamed mucosa in some mucosa tend to show more prominent staining. And there's a controversial entity called intestinal neural dysplasia, where you tend to see positive, but they are not true Hirschsprung's disease. False negative is much more common, and I said the equivocal results and negative results are common. And it's important to know that you will, if someone gets your laparoscopic biopsy, just trying to see whether it's Hirschsprung's, and it gives your biopsy from transverse colon or anything beyond spleen, you don't expect nerve hypertrophy, because parasympathetic fibers come from the sacral units, and they go proximally to a finite distance. They never reach beyond splenic fracture at all. So biopsy here will not show parasympathetic hyperplasia. Not only that, as you go up, the parasympathetic hyperplasia diminishes, and then it's very high. So to pick up parasympathetic kind of acetylcholinesterase abnormality higher up, so it is much more easier to pick up, and if it is present, it's going to be here. Not only that, when you have a total colonic ganglionosis or a long segment ganglion, it's likely that there is in general a wider there is a much kind of broader problem of neuronal crest. So there is chance that even the parasympathetic system is abnormally developed. So you will not, the enteric nervous system is not developed, as well as so you will not see this kind of parasympathetic hyperplasia. Another aid which has come on recent, not recent, but now 15 years now, is the calretin positive nerve fibers as an indicator of presence of enteric nervous system. And it was seen that proportion of enteric neurons and nerve fibers show expression of calretin, which is not there in the extrinsic innervation. And so if you see calretin positive fibers, it shows that the enteric nervous system is present in there, although you're not seeing a ganglion cells, or may or may not. And the good thing about calretin is that you don't require frozen sections, which is essential for ACHE, so that we get all our biopsies fresh, and so you can, makes things much easier. Negative and equivocal results are not there. Mostly it is positive or negative, and if the enteric nervous system is not there, it is Hirschsprung's. You will not see calretin positive fibers in the lamina propria or and the muscularis mucosae. Even in a long segment, because there are no enteric neurons, so even in long segment disease is consistently negative, so that that's very helpful. And interpretation requires less experience. In fact, it's pretty straightforward, positive and negative. I'll show you some caveats, and then you know. So this is what you see in a Hirschsprung's disease. There are no staining stained fibers in the muscularis mucosae or the lamina propria. You should, in this case there isn't, but you can have occasional nerve staining in the submucosa. So, but you focus for interpretation of Hirschsprung, you shouldn't have any nerve fibers in the muscularis mucosae and lamina propria. So this is an example of a Hirschsprung's disease where a thick nerve fiber is showing positivity of calretin, but there's no positivity in the muscularis mucosae and the lamina propria. These cells, what you're seeing, are the mast cells, very common, and these are used as an internal control. So for interpretation of Hirschsprung, remember you're looking for fine fibrils like this in the muscularis mucosae and lamina propria. If absent, it is Hirschsprung's disease. Another caveat is that you can have calretin positive in a ganglionic segment of Hirschsprung's disease, and this happens because of the fact that so in a neuron there's a cell body, and then there is axons and dendrites. So, and which can go very long. In the enteric neurons can be as long as 1 to 2 centimeters. So they can extend, the nerve processes can extend from a ganglionic segment into a ganglionic segment for up to 2 centimeter theoretically, and so there are cases of a very short segment or short segment Hirschsprung's disease where calretinine is going to be positive, and so it's important to remember that. So now you've got all the things in your I'm telling you now that you can look for ganglion cells on a chinny stain with a lot of serial section. You can look for enteric nervous system innervation by using calretin fibers in the in the lamina propria and muscularis mucosae. You can look for evidence of parasympathetic hyperinnervation by thick nerves or thick nerves with GLUT1 perineurium, acetylcholinesterase staining. And for long there was no immunohistochemistry correlate for acetylcholinesterase, but recently we've acquired an antibody called choline transporter, which replicates kind of acetylcholinesterase kind of pattern, and this. The good thing is that now you can use it on paraffin section sometime when you get cases from outside referred when you don't have frozen section. Having said that, it is going to be difficult. So you have to, the way over the years we have developed experience to interpret acetylcholinesterase, I think we can need a similar experience to interpret choline transporter. This is a much more difficult stain to interpret as compared to acetylcholinesterase. So there are much more equivocal results in it, but if positive, if you start seeing a lot of choline transporter positivity, you can conclude the case as Hirschsprung's disease. Now, so that's what you see. A typical case would be an infant, and what you see would be absent nerve fibers. You in a lot of serial sections, you get thick nerve fibers, calretin, even no calretin positive fibers, but a lot of ACHE coarse ACHE fibers which are running into the lamina propria. In a typical case like this, you can make a diagnosis on Hirschsprung's disease provided you have seen a kind of decent amount of sections. So you've an adequate biopsy and you've seen 60-70 serial sections and not seen ganglion cells, and there are definite thick nerve fibers. You can make a diagnosis without any techniques. We do it all the time because because we can do it, and we just to stay safe and then secure, we do calretin and ACHE to confirm the diagnosis, but you can make a diagnosis on HE alone. However, I think there's a mistake there. So in a rectal biopsy less than 1 year old, you can make the diagnosis. In an older child, so there's a correction there. So in older child, I'll say it is quite suspicious because I told you that you can have nerve hypertrophy in normal children over kind of 1 year of age. So I'm more suspicious and like to have either a calretin confirmation or ACHE before giving that diagnosis. In an older child. In a young infant, that's fine. And so once you have any of these ancillary tests positive, you conclude it as Hirschsprung's disease. In fact, for rectal biopsy of any age, if you have an abnormal ACHE pattern, you can confirm. I think it's very similar to the old slide, but I think I mixed it up. But once you have no ganglion cells in more than 75 serial sections and ACHE positive, whatever the age, it is Hirschsprung's disease. Similarly, you can use this combination where no ganglion cells in a lot of sections and calretin negative means no positive fibers. It is Hirschsprung's as well. So when you have no ganglion cells in a non-Hirschsprung's biopsy, because you always think you're not seeing a ganglion cells, can it still be no Hirschsprung? So mostly it is because of the sampling issues. So you're literally seeing too little submucosa there. So that's why adequacy criteria comes in. If you have low biopsy, again, it's hypoganglionic. That's why you're not seeing ganglion cells. There may be technical issues. Sometimes there's a staining problem, creases, and then you may have crush artifact or lymphoid tissue obscuring submucosa. And there are times, much more rarely, when there are interpretational issues, and probably it's good to show to your colleague to make a thing. Now, let's try to see some of the scenarios where you're not seeing a ganglion cells in a suboptimal biopsy. So you're not able to do 60 serial section, or it is low, or it is a kind of just submucosa is not 1/3 as we normally like to. If there is nerve hypertrophy present and ancillary studies, any of the ancillary studies is present, you can call it Hirschsprung cell. There's no need to say repeat the biopsy because we're not seeing 60 serials. So that's something which I want to say. If you have got classically abnormal ACHE or calretinine, along with even a suboptimal biopsy, you may conclude it as Hirschsprung. However, if nerve hypertrophy is not present, or none of these are classical, it's better to repeat a biopsy, and probably in those cases, many of the time you go on to find ganglion cells. There's another scenario where you're not seeing ganglion cells, there are hypertrophic nerve fibers, but then there is a calretinine positive mucosal nerve. And with the kind of explanation which I've given you earlier, that calretinine positive fibers can extend into the aganglionic segment for about 2 centimeters in a condition where a very, very short segment of Hirschsprung is there, it's likely that you may not see a ganglion cell because they're ganglionic, but those fibers which are encroaching from the ganglionic segments are seen. So in these cases, you suggest a possibility of ultra short segment Hirschsprung's disease. If in an older child, however, this is more likely to be a hypoganglionosis. So what I'll do, I'll cut through the block, I'll do a repeat biopsy, and because many of these older biopsies come in formalin, you like ACHE to be done on them, so you kind of repeat the biopsy, and you may we have diagnosed ultra short segment kind of Hirschsprung's disease, but this is usually done on a repeat biopsy when you have not seen ganglion cells in decent amount of tissue, and you've got abnormal ACHE as well to go with. And this is a very thought-provoking article published by Dr. Raj Kapoor, and where they are saying, are we underdiagnosing Hirschsprung disease? And it's based on the premise of that there is a chance that we are missing a very short segment Hirschsprung's disease with a long transition zone. Now, just to explain what's happening here, this is really good illustration of what we want to tell about this. In a normal individual, the ganglion is right to the anus. There's normal innervation. You see ganglion cells and the internal anus sphincter is normal. In Hirschsprung's disease, which we have talked so far, there's a red zone of aganglionosis. Then there is a zone of transition zone where the innervation is abnormal, but ganglion cells are still present. And then you have a normal ganglionic area. In a very short segment Hirschsprung's disease, what we see is this zone, the red zone, is very small, and what we see is straight away go to a transition zone, and where there are ganglion cells, but the innervation is not entirely abnormal, so the bowel may not function normally. What do we do after the surgery is we remove not only the red or the aganglionic zone, we have to remove the transition zone as well, which is functionally abnormal in many cases. That's what we believe, and then you expect relatively better results. Now, what they are proposing, that there are going to be possible cases where it is not, the aganglionic zone is so small that it can't be diagnosed as such, but there is a decently long transition zone which will have functional similar consequences to any other Hirschsprung's disease. So these cases might have a kind of surgical cure if we diagnose them. Probably at the moment we are not diagnosing. There's another entity called internal anal sphincter achalasia, where the bowel itself is normal up to the rectum, but the internal anal sphincter innervation is a problem, and it's kind of hyperactive. It doesn't relax. And they base this kind of the proposed possibility of this thing based on experience of their cases where they had a biopsy and they mapped and they found that the ganglion cell density and even acetylcholinesterase was abnormal in these kind of very distal biopsies. And we have got similar cases in our archives, and probably there may be some reason to believe this hypothesis. So what you see in this case is as an older child. As I said, many of the older child, you get a bigger biopsies with this kind of full thickness or kind of at least a little bit of muscularis as well. And we didn't find any ganglion cells in this, but ACHE is abnormal. Calretinine was negative. A negative means that there are no calretin positive fibers here. These are the mast cells, what you see, so don't interpret them as positive. Now, as I said, an older child, you're more likely to be a situation of hypoganglionosis, physiological or pathological, rather than ultra-short Hirschsprung's disease, but still possible. So in these cases, we repeated the biopsy and repeated the immunostain as well. And what we found, there were scant fibers of calretinine in the lamina propria as well as muscular. So it is, that the enteric nervous system is present. The only problem with the older biopsies is that you need a lot more sections than a section rectal biopsy in infant, and the reason being, so you've got a normal, you've seen this picture before. Now, once in older children, the rectum expands because it's kind of megacolon developing. You need far more sections to actually pick up ganglion cells. So in these cases, you probably need to look for 150 plus sections before you actually see it. And in that case, what you've shown earlier, we did find ganglion cells in the same biopsy at around 200 sections. So in an older children, you may struggle to find ganglion cells and things may be really atypical. And this is we get to normally, so we get a rectal biopsy which come fresh from theater, and we, if it's a kind of more than 3 millimeter, we bisect each of them, freeze one half, process the other half for paraffin section. If they are smaller, we would decide to do one way or the other, but at least one of the biopsy would be frozen, and usually the distal most. Now, once you've made a diagnosis of Hirschsprung's disease, now it's time to manage it, and the definitive treatment is surgical. It could be 1 stage or 2 stage, depending on the condition of the child. If it is, so the 1 stage is where you just straight away go for pull-through, where you're going to pull the segment of ganglionic segment to the anal canal. So the main goal of the treatment of patients with Hirschsprung's disease is to resect the aganglionic segment and pull down the normal ganglionic bowel, and that must be anastomosed to a rectum above the anal canal. And this is important because you want to preserve the sensitivity of the distalmost part of the rectum as well as the sphincter mechanism. So the resection, you will leave part of rectum when you're doing the surgery, and this is to protect the sphincter and sensitivity. And during surgery, you're going to be playing a very important part by telling the surgeon which is the ganglionic part first, because then you don't want to pull through aganglionic segment or transition zone. And normally in many centers now, if most of the cases will go kind of parental, kind of transanal pull-through procedures where the incision is made deeper to the sphincter, and then the bowel is pulled out, and the surgeons will be giving biopsies where he thinks it's transitional zone in every 5 centimeter. And these biopsies are the seromuscular biopsies, and you get serosa, then you get outer longitudinal layer and part of inner circular layer, and you're looking for ganglion cells here. So if surgeon is giving you this, you say it is aganglionic. These biopsies are much easier to interpret as compared to submucosal, because in a normal bowel, the density of ganglion cells is far more in intermuscular plexus, and it's not difficult to find them in a normal ganglionic a good biopsy. So they're much easier to find, they're much more numerous. If you're struggling to find them, or you're finding some dubious ones, probably it is not. So your threshold for diagnosing ganglion cells in kind of perioperative birth should be really high. The only problem sometimes you may get is because of the orientation. So you may not be in the right plane. There are a lot of gaps which appear like that they are within the plane of the 2 muscle layers, but actually in this case this was just a gap which has been sectioned. So this is not an intermuscular plane, the proper one where ganglion cells are. This is just lymphocytes. So you should be aware of lymphocytes being interpreted as ganglion cells, or trying to look in a wrong plane. So actually the plane in this particular biopsy was higher up, where there were really ganglion cells very easily seen here. And the key to orientation is, when you get a biopsy, I don't have a gross picture, what will happen that once you cut a muscle, they always contract. When they contract, normally the surface would be curved. So when you're embedding it, never embed the curved surface. So embed it at the right angle to the curved surface. So you're always going to see the muscle layer and the intermuscular area. So once you've confirmed, so you got a couple of biopsies from here and here, you said this was an aganglion, you said this one is ganglionic. The surgeon, what they'll do now is going to cut it, what we say in a short segment, at least 3 centimeter above, sometimes 5 centimeter above, and they're going to give you a cuff from here, which is, we call it donut. And it is quite important to evaluate these before a surgeon actually makes the anastomosis. So what we get is, this is a donut here, and we embed it full circum. Sometimes it is big, then you can embed this in 2 halves. And this is being done to identify a transition zone. We don't want to pull through transition zone, which will be making the whole of the surgical procedure more likely to have kind of suboptimal results. So what do we see in the transition zone? The commonest finding near to the ganglion zone is segmental absence of ganglion cells. You may see ganglion cells here, part of the circumference, but the part of the circumference doesn't have ganglion cells. And so that's abnormal, and you don't want to pull through this. So you say it is not. Another thing what you see is nerve hypertrophy, which we have all talked. So if you're in a proper ganglionic zone here, there is no parasympathetic hyperplasia or thick nerve fibers. If you're seeing thick nerve fibers, again, that is abnormal. So these are the 2 things which you're looking for, and some more findings which I'm going to tell you when you're examining your donuts. So the features which we look during frozen section is partial circumferential aganglionosis, myenteric hypoganglionosis. If it is really obvious, then, so I'll tell you what it looks like. Another thing is you get hyperganglionosis in the submucosa. So you got less ganglion cells in the intermuscular plane, but the submucosa ganglions are more. It is much harder to detect in the frozen section, so probably you'll not, if you see it, it's fine, but you will not. And then you talked about hypertrophic submucosal innervation. There are different features, many different features which are described in transition zone histology, and so we've talked about aganglionosis. Hypoganglionosis, it's much harder to appreciate in frozen section, but you'll be seeing it in pull-through, which is a bit late because surgery has been done. Abnormal extrinsic innervation, you can see in frozen section, so you should look for. And then ectopic ganglions, you may see, and if I see, I just tell the surgeon probably this is still a transition zone. So when we're looking for aganglionosis, even in a we try to divide. So you get a donut here, you try to divide in 8 segments, and if aganglionosis is present in more than one sector, which is 1/8, you report it as abnormal, and probably surgeon will give another donut higher up and to confirm what's happening there. And what you see here is that this area is hypoganglionic, although we are seeing submucosal ganglion cells, but the myentic plexus is hypoganglion. There are no ganglion cells here, so I say this is still transition zone segment. You can see ganglion cells, but no ganglion cells in the muscle. There are no ganglion, the whole sector, there's no ganglion cells. In this biopsy, actually 2/3 of the circumference was ganglionic, and you can see ganglion cells in the submucosa here, so it is nearly there, but still abnormal. Another common thing we see is kind of nerve hyperplasia. The nerve hyperplasia is more important in the submucosa, and you measure the two, so they're more than 40 microns, and if you see in a high power field 2 cross sections of more than 40 microns, it's abnormal. And another finding which have been described in subset of ganglion is fibromuscular dysplasia, and this occurs commonly in transition zone. Not commonly, sorry, about 5 to 10% of cases where you get these kind of thick, smooth muscle bundles. Another finding which I told was submucosal hyperganglionosis. Sorry, this. So hyperganglionosis is described as more than 8 ganglion cells in a cluster of ganglion, and again you can see one odd giant ganglia. That's not important. The density in general should have increased. So if you're seeing a lot of them, as in this case, you can see 8 here, 9 here. In fact, I'm not able to show this picture behind. Somehow there was a loss. It is abnormal. This is from the paraffin section. I have not appreciated this finding in the frozen section. Probably the time wasn't much or something. So. Another finding you see is the ganglion cells are misplaced, ectopic ganglion cells. So these are the features of transitional zone what we've so far seen. You got seam ganglion, which is much deeper in the circular muscle layer, scattered ones there, and so you've helped the surgeon with the thing, and that okay, with this the last donut what you've given looks like properly ganglionic, and then what you get is a pull-through specimen. And although you can't do much because the surgery has been done, but it's important to evaluate these. Sometimes you in these kind of specimens you may find abnormality in the proximal resection margin, and you think the sum of the kind of difficulty which the child will have later on may be attributed to this, or as a transition zone pull through. So this is a typical specimen that you get. As I said, the distalmost part will not have muscle because that has been retained in the body. If here they do a submucosal resection, so the mucosa sleeve would be there, and then you start seeing a full thickness kind of bowel, and then here you start dilating. You know it's a transition zone possibly, but only on histology you can make out. So you will take the proximal resection margin to look whether this segment is normally innervated or not. What we do now, it's not essential, is to map the transition zone. So we take transverse sections of full circumference 1 centimeter apart and look for transition zone features, and then take a longitudinal section of the remaining length to evaluate. So, and usually if it's a fresh specimen, you make a Swiss roll, and then you can, one single section, you can see the entire length and evaluate. So this is our practice. It need not be the best, and a lot of different practices in the world. Some may be better, and one of the groups. This is the kind of practice what is done by Mir Rouge and Dr. Bruder in Switzerland. So they don't fix their sample in formalin. They do the entire resection specimen as a Swiss roll and freeze it and do enzyme histochemistry rather than looking the way you look at. But by and large, all the necessary information probably you can get it from normal H&E sections, and these are not required. But I've said that there are different practices in the world, and nothing is right or wrong. I didn't manage to. This was because some of the stuff is old, so I didn't manage to get the newer data. But 90% of the diagnoses are kind of in 90 below 1 year age, and then you get most of the diagnosis made on suction. I find diagnosing Hirschsprung disease in older children is much more difficult, and because a lot of secondary changes, and I told you the density of ganglion cells is much lower. So what to diagnose aganglionosis, you have to see far more sections. As I said, how are we doing time-wise? So we are okay.
There's no issue about time. There's no issue of time. Just go ahead.
Okay.
We're really enjoying it. Go ahead.
All right, then that's good to know. Otherwise, yes, it seems like you're talking to the screen and okay. So the intestinal dysmotility can be because of, I told you, there's a lot of other players. There's muscle, there's enteropath, kind of glial cells and everything. So any abnormality could lead to intestinal dysmotility, and so broadly we classify them as neuropathies and myopathies, and some of the are combined. I'm not going to talk about myopathies. As a really interesting group of disorders. We're diagnosing more and more now, and then within the neuropathies we've talked about Hirschsprung's, and then there is a lot of other things like hypoganglionosis, hyperganglionosis, which we talk about, and retarded neuromaturing gliopathies. Gliopathies we very little know, hardly any publications, and probably I'll not be able to talk much about it because I've got no experience. Now, congenital hypoganglionosis is very difficult. Now, if I ask you to tell which one has got more dots, it would be struggle, but actually I have put fewer dots on this one. So this is something not diagnosable by the kind of skills I have got. On the other hand, if the extreme hypoganglionosis, where things are really different from the normal looking intestine what I see, I make a diagnosis. So severe hypoganglionosis is much rarer. So people have described kind of done morphometry and all, and they can't possibly pick up more hypogangliosis than what I do, and to an extent that there's a group which has described that nearly 15% of cases of coronary constipation in their series had hypoganglionosis, which is not our experience, but as I said, we are limited by our skill. So etiology again is not known. There is some clinical, epidemiological, and pathological similarity to Hirschsprung's disease. And I'll tell you one thing. Hypoganglionosis can be congenital or acquired, and the acquired ones are very different, and they tend to occur higher up, so they don't actually involve the terminal part of rectum. But the congenital hypoganglionosis, there are typical examples, and we have seen ourselves, which have very typical clinical presentation, very similar to Hirschsprung's. Sometimes radiology is very typical, very similar to. So you got a spastic segment, a distal segment, and it probably is different from Hirschsprung's, but clinically and radiologically may resemble. And morphologically, what we tend to see, it tends to be similar to the transitional zone morphology. So you have got a reduced density of ganglion cells, and then you see a nerve hypertrophy in the distal rectum. So you see those features, but you have ganglion cells, but they're far sparse. In these cases, sometimes, because ganglion cells are actually present, you will see calretin positive fibers. Sometimes they are normal density, I don't know why, and sometimes they're reduced. For diagnosis of hypoganglionosis, you will need a full thickness biopsy, and the whole reason is oversampling bias. And you know how difficult it is to pick up ganglion cells and how difficult it is to pick up reduced ganglion cell density. So you will not make this diagnosis on a suction rectal biopsies. And another important thing is the hypoganglionosis is maybe restricted to or more often in the myenteric plexus. So you need a full thickness biopsy. And so you need a full thickness, couple of centimeters of bowel to say it is hypoganglionic. And this is one example where you can identify scattered few ganglion cells. And what actually happens in these cases, they are not only the ganglion cells are spaced apart, they are fewer in the similar clusters. So severe hypoganglionosis is characterized by lengthy stretches of myenteric plexus where you contain only individual ganglion cells like here, or ganglion cells, there are a couple of ganglion cells sticking together, but not the larger ganglion cell groups. And there is deficiency of neuropil surrounding this. So you don't see glial cells also that many. Now, arguably, that you can manage if you're very sure that it is distal affection and it is congenital and it is happening. These cases may be kind of treated by surgical resection and with a similar results as Hirschsprung's disease, but most often they are diagnosed much later and then probably medically managed. In this case, there was nerve hypertrophy as well, so you have fewer ganglion cells with nerve very similar to what I've been showing for transitional zone morphology. So one argument could be, is this a very short Hirschsprung's disease, where it's everything what you're seeing is basically every time you biopsy, you're going to see a transitional zone morphology, and which is likely, in fact. There's another interesting group of disorders called intestinal neuronal dysplasias, and there are believers, there are agnostics, and there are atheists about this. And I am somewhere in between. So probably I know that because of the complexity of the kind of enteric nervous system, you're bound to have disorders other than Hirschsprung leading to problems. So that part I accept. But whether these changes what been described actually are the kind of secondary results of primary pathology explaining the problem in a child. And it was first kind of described way back in 1971 by Mir Rouge. I think he's the stalwart in this. He described a lot of things in intestinal motility disorders, and he is described based on histochemical stain. I think it is the same group that Dr. Bruder has worked with Mir Rouge, and they have published a lot. And they've maybe been able to diagnose all these disorders because they do histochemical stains. which we don't do. So we do ACHE, but we don't do other things to pick up neuronal immaturity or neural. So since the description 1971, there have been a lot of modifications to the criteria because of kind of inconsistent literature and problems with the criteria themselves. There are two types described, type 1, type A, type B. Type A is considered to be a congenital malformation of sympathetic nervous system, where the sympathetic nervous system innervation is either absent or severely hypoplastic. And this very much resembles the innervation in a premature infant. So we've also seen sometimes that if a biopsy from a premature infant may show a lot of features which resemble the type A as well as type B. I'll tell you later. IND. So the diagnosis of IND-A shouldn't be made in an infant less than 1 year, and so if these changes, this poor innervation persist, then you make the diagnosis. The classical presentation is with severe constipation, but also what is called as a very inflammatory ulcerative colitis or like picture in an infant. And in the usual biopsy, what we do, we see severe kind of ulcerative inflammation, and in these biopsies you will see increased ACHE positive cells, fibers in the lamina propria. However, the diagnostic feature is aplasia or hyperplasia of sympathetic innervation in myenteric plexus, which can only be recognized by catecholamine histofluorescence. We don't do it. I know I have cases where I have suggested it once in 5 years or 6 years, where it is kind of very much like inflammatory bowel disease. You see that there's inflammation, the mucosa is ulcerated, and the patient has presented with constipation, bleeding per rectum and all. Some of them have turned out to be mutations commonly seen with immune systems. So one of the case ultimately turned out to be immunodeficiency of one kind. So I don't know whether this entity exists, but we don't do histofluorescence, so I don't know whether I'm missing it or not. Now, treatment-wise is they say surgical resection, but as I said, if a child has got necrotizing enterocolitis, if you are bound to resect it, and so normally you're not kind of making too much difference. Not diagnosing is probably because if they have got really bad disease, they'll be surgically treated anyways. IND-B has got much more chronic presentation, so they tend to present with chronic constipation, abdominal distension in older child, but enterocolitis is much kind of not as common as in Hirschsprung's. And it is different from Hirschsprung because there's no gender bias, and there's no consistent genetics which have been described so far. So how is IND-B diagnosed? So it is considered to be a malformation that possibly results from incomplete maturation of submucosal plexus. And the reason it's typical, one of the key features of IND-B is hyperganglionosis of submucosal ganglia. So you have a giant ganglia that is more than 8 ganglion cells quite frequently. So they are much more densely packed as well as they are bigger. Now, this is a finding you can see in premature infants, and even infants. We've seen it in a 6 to 8 month old child as well. So it's when to diagnose IND-B is important. Now, as I said, the IND-B diagnostic criteria has been kind of modified again and again by the same group, mainly the Mir Rouge group. And the current criteria is that patient must be older than 4 years. And this is because, I was telling that you can see giant ganglia much more numerous in a younger age group. And people say it normalizes only by 4 years of life. So you don't, before diagnosing INDB in a younger infant, be careful about that. Now, it's much more morphometric criteria are there, so you should examine at least 25 submucosal ganglia. So you need a bigger biopsy. You can't do this on a submucosal biopsy, kind of the usual biopsies what you get for Hirschsprung's disease. And a giant ganglia definition has remained same, more than 8 ganglions. And now there's a quantitative criteria. So more than 1 in 5 ganglions out of minimum 25 what you've seen should be giant. So if you're seeing 1 odd or 2 odd ganglia with 8 ganglion cells, I would regard as normal. So don't jump to diagnosis of INDB. In fact, another thing I want to tell you, most of the description of this entity has come from the Switzerland group, and they have described this density and counts based on histochemistry, lactic dehydrogenase and succinate dehydrogenase. We don't do routinely, and not many people do in the world. So, but there are cases like this. This is one of our cases in a kind of 1.5-year-old, where there are giant ganglions, more than 8 ganglions, 9 ganglions, closely packed together, very similar to what you would describe as INDB. And this is another case, sorry. And this child was constipated, but I think we have a decent follow-up, decently managing on medical treatment, and in fact, it's not severely constipated anymore. So I don't know whether we'll get a biopsy or not, but there's a chance that this is because this is younger infant, and up to 4 years it will normalize. And I don't know whether this is actually the correlate for the constipation he's had. So that's the problem with this diagnosis, and that's why you have believers and non-believers of this entity. Okay, this is an example of interstitial ganglion neuromatosis in the case of neurofibroma, so just ignore that. These can present as constipation. So that's fine. I'm trying to wind up and show some rare cases which have presented with constipation and had diagnosis other than Hirschsprung's disease. This case was presented with constipation but had a normal neonatal course. So it was atypical, but we're looking for Hirschsprung's, and we found T-cell ganglionitis. Many of these are kind of post-infectious or sometimes paraneoplastic. Just leave it there. And what I'll do here, I'll switch gears here and just share some of the work which you've been doing on Hirschsprung disease stem cells. So the management now is surgical, and it works very well in many patients. But there's a problem for very long segment disease because they lose a lot of long lengths of colon, and they have problems. So the premise was, can we somehow harvest ganglion cells from these patients and kind of somehow transplant it and make them functional in humans ultimately? But this study is obviously, it's just from the animal. So what we did for this study was, this is a pull-through specimen. We cut samples from the aganglionic zone and as well as higher up in ganglia, and we confirmed it on histology by various means, and there was really aganglionic. We take a 1 centimeter cube of this, made a suspension of them, and cultured them. And if there are kind of neural precursor cells present, in a culture cell they form neurosphere. And if you repeatedly culture them, you tend to have a lot more stem cells after multiple cultures, and we sorted them based on P75 expression, and then we have a model of aganglionosis in mice where we transplanted those cells and try to look for what happens there, whether they colonize the bowel, aganglionic bowel, whether they differentiated into cells, on whether they have any effect on motility. So that was saying, and this was one of my colleagues' PhD work, and so there's some pictures. Now, when we examine by dual staining of P75 and calretin, what you're seeing here is the ganglionic zone. So we see that there are P75 positive cells, but then they also have a calretin expressing enteric neuronal cell. So this is the ganglionic zone. When we look the same in the aganglion zone, we saw that P75 positive cells were aggregating around these nerves. The nerves are empty in Langsing because there are no calretin positive fibers in them. And same thing, you can see the thick nerve fiber here in aganglionic zone and P75 right. So there are possibly P75 expressing cells in an aganglionic segment as well. This was so people have cultured stem cells and done the similar experience from ganglionic zone, but it was not done before on an aganglionic zone, which is more likely you can get a sample in the cases. We sorted for P75 cells, so and then in the sorted, after sorting, you can see most of these are positive. And in the cultures, when we stained for P75, we saw that the concentration of P75 cells were increasing, but then there were cells differentiating into zinc cells. So we start with a P75 positive cells from an aganglionic zone which had no calretin and no VIP, no NOS, which was seen earlier, start expressing calretin and VIP and NOS. So the proportion of them can start differentiating as well. So you can make them differentiate in culture at least. And then we did was transplanted in a ganglionic so aganglionic mice intestine. So here what you're seeing in aganglionic segment, there are no human derived cells. The one you're seeing HNRP is basically human specific ribonucleoprotein. Obviously this one has got no transplant cells, no human cells, so it won't show positive. And in an aganglionic control, obviously not. But once we inoculated it, it moved through the segment of bowel, and we started seeing human enteric nervous stem cells or stem cells, which we have cultured from humans, colonizing it. So that was a successful experiment. And not only that, they started expressing other neural marker differentiating TUJ1. Now, this aganglionic control, which had no human transplanted cells, did not show any TUJ1 expression later on. And in our case, when we inoculated it, it was colonizing the bowel wall. Okay, it has we have made them to differentiate. At least they look like they're starting calretin in TUJ1, but are they really functional? And so we did a kind of functional assays where we're seeing the contraction pattern in these muscle segments. And normally in a normally ganglionate segment, you get a pattern like this. Whereas in aganglionic control, you get a very kind of like a fibrillation pattern. So you get a very, very frequent, very highly frequent thing. When we transplanted them and they settled there, the movement was much more similar to the ganglionic segment. So I think this experiment can prove that you can isolate stem cells, you can make them differentiate, you can inoculate, and you can possibly make them functional. And so that was where this was done quite a few years back. Then we tried to do the same thing with a kind of total colonic aganglionosis thing, and we couldn't replicate this finding. And then the whole reason why I think is that the stem cells reside around the extrinsic nervous system, so there must be some neural kind of some neuronal precursor cells, stem cell properties in cells surrounding the nerves in the perineurium, which actually I've told you again and again, when there is a generic kind of defect in the neural crest cells, the parasympathetic system doesn't develop. You don't see nerve hyperplasia, and obviously when there's no nerve hyperplasia, we're less likely to find stem cells around them. And our work kind of continues. Now we are seeing what other neurotransmitters they accept. Do these cells differentiate in all different types of neurons which are talking about? And it's kind of still work in progress. And I'll stop here. Thank you very much.
Thank you, Rajeev sir.
Thank you.
Excellent insight, fascinating insight, if I may add, to this really complicated matter, Hirschsprung disease. It's really enlightening for all of us, I must say. And we can take a couple of questions the viewers have posted. I will start with some questions we have on the YouTube channel. Professor Dr. Pranab Kumar Bhattacharya, incidentally, he is the head of pathology of Calcutta School of Tropical Medicine. So he has a question. He asked that what is the prevalence of Hirschsprung disease, and why does it affect more male children with a more male to female ratio of around 4:1?
If you can just stop presenting, then we can see your face also.
Okay, I'll just see. Okay, that's good.
Yes, sir.
Can you see me now? Yes, so I think, as I say, there are a lot of things we don't know, and a lot of genes, what we're seeing as if red, GDNF, none of them actually are on X chromosome or something. So I think there are a lot of kind of facilitatory things which might be important in this. So you need to have red defects as well as any other polymorphism or any other kind of sex chromosome driven or hormone dependent thing which facilitate expression of this profile. As I say, it has got incomplete penetrance, so you may have a gene but you may not express. So what those facilitatory things are probably would influence the sex predisposition. But actually I don't have the answer.
Thank you. Professor Bhattacharya has another question that what do you think regarding the pathogenesis? Which should you consider the most important? Either it's A, degeneration of ganglion cells, B, target cell migration from primary neural tubes to neural crest, or a red proto-oncogene mutation?
Okay, I think all of them are important and possible. Now the people have described that migration is the key, so incomplete migratory arrest is key. Now whether, again, as we talk in tumors also, that the environment is quite important. So why is it that a neural crest which was migrating up to a particular area, so it was present in, say, transverse colon, but is not, it fails to kind of develop later on. Most of the studies which have in the models, we have seen it is a proper arrest. So you may have some degeneration in the middle portion of it, but the common Hirschsprung disease, the classical ones, is because of that. The degeneration is more important in segmental aganglionosis. I didn't show you a case of that, but what happens in them is that you have the distal portion which is normal, ganglionic, and then it's a middle segment somewhere that is aganglionosis. And it is these where degeneration or secondary destruction plays a more important role than the primary kind of migratory defect.
Thank you, sir. Another question Dr. Bhattacharya is posting is what is the sensitivity of acetylcholinesterase stains, particularly with false negative?
False negative, where it is abnormal, where it is, okay, false negative. So ACHE in a term neonate, the sensitivity is quite high. It's a 95%. In a premature infant and in a long segment disease, it goes down. So as I say, in the long segment disease, you don't get parasympathetic hyperplasia, so you're less likely to see ACHE positivity. So you can have a normal ACHE in up to, in a long and in up to 1/3 of cases, in fact. So sensitivity of more than 90% in cases of term babies and classical Hirschsprung disease, sensitivity much lower, around 75% in cases of a longer segment disease.
Thank you, sir. And another question is how much incidence of Hirschsprung disease with Down syndrome?
I think so. I think that you may find this very easily somewhere. At the moment, I don't know. So, what is?
I think, sir, you had mentioned that 80% cases were non-syndromic. So the
yes,
rest of cases.
Although that Down syndrome is very few. I think you're talking about 1% or 10, less than that. Yeah, around 1 to 5%. Offhand, I don't know. Sorry, don't quote me.
And Minesh Gandhi has a question in post-operative cases, how to handle transition zone pull-through specimen by the pathologist. I think you have addressed this with a nice picture of how to gross the specimen, the transition zone and the aganglionic segment. I think that is answered. And he has another question: in real clinical practice, does hypoganglionosis really exist, and how to report them?
Okay, as I said, you will not make a diagnosis of hypoganglionosis on a mucosal, kind of submucosal biopsy. The hypoganglionosis of Mayentrix, you should have a full thickness biopsy, a reasonable size. You can suspect, and we have done that. And how do you suspect that? So if you got a full thickness biopsy, but I'm not talking about big biopsy or the usual biopsy, where you have, say, done 150 odd sections and you're not seeing ganglion cells, calretinid fiber tend to be scanty in these cases, and ACHE is not abnormal. So if ACHE is abnormal, you are more thinking in terms of ultra short Hirschsprung disease or something. So ACHE not abnormal, calretinid slightly abnormal or kind of scanty, and no ganglion cells in a decent size biopsy. You're suspecting a thing, but you not make a diagnosis. You say, can you get a bigger sample or multiple biopsies? And usually won't get it until the clinician thinks that this child is really difficult to treat, and we are going to, so many of these cases actually we are going to, if you know that chronic constipation is occasionally treated with resection of the megacolon. So if consultant, the surgeon thinks that it is that category of severe constipation, they might try to investigate further. And another thing I probably, I told you was that ACHE is really important, and people are just switching to calretinin, and it is easy that 95% of cases you can work up with the combination of HNE and calretinin. creatinine. But then there are these subset of difficult cases, which are really difficult, where ACHE is going to be discriminatory. Whether another thing, what is the treatment? What is coming along is a Botox. My personal thing is Botox is more likely to work if there is hyperinnervation. So if ACHE abnormal, Botox injection to kind of sphincter is more likely to work. So if you have a hypoganglionosis and then with normal ACHE, I think the treatment with Botox may or may not help. Another thing is what we don't do. Another thing is, or we're not very good at, is manometry. So in these difficult cases, if you do manometry and there is absent reflex, which then you're thinking more in the category of internal sphincter achalasia and ultra-short Hirschsprung's disease. Now, again, we always want, there's some distinctions we'll never make it, but we want to help the surgeons to manage. At the moment, most of the centers are managing ultra-short Hirschsprung's disease and the sphincter achalasia by Botox or medical treatment, and probably that will stay the mainstay, medical management will stay. But then probably there is a category of ultra-short Hirschsprung disease with a long transition zone, which could possibly be treated better with surgical resection. The whole problem is we don't know how to diagnose them. So I think a lot of to and fro communication with the surgeon and the whole community to identify these and treat. And it is this group possibly which go on to have a long-term problems in the life of refractory constipation, incontinence, megacolon. Are we just kind of really missing out these cases which could have been better managed surgically?
Thanks, sir. Professor Bhattacharya has a question. Use of Giemsa and tall blue stain in frozen section for the diagnosis of ganglion cells. What's your experience?
No, I've done use it occasionally. It works very well. I think Dr. Bhattacharya is really spot on that.
Yes, sir. I think we also used to do in PGI. I remember. Tall blue. Yeah, tall blue was a
Yeah.
And sir, I personally have one question. There's a group in St. John's Medical College, Bengaluru. They have a unique way of a double re-embedding process. Of first to embed the tissue into the gel agar, and then after fixation they re-embed it into the paraffin block. So they say that the orientation wise and the yield of the tissue is better this way. So your comments on that?
Oh, I have no experience, but it sounds interesting and probably works better, definitely. Yeah.
Okay.
In fact, again, for another different practice is people doing ACHE on frozen section, peroperative frozen section, because there's a rapid AC available. I personally feel that is not required. As I've shown you, it is discernible on HNE more often, but people want to if people feel confident, add in extra layer, it's fine.
Okay, sir. Do we have any other questions, Nadeem, sir?
So there's a question in the chat box from Dr. Oscar Hermandez from Mexico.
Yeah, I think. Okay.
You can address that.
Any procedural guide for the rectal biopsy in patients suspicious of Hirschsprung? And how to classify a case with absence of ganglion cell on one of the two plexus?
Okay. Yes. So as I told you that by and large migration occurs in sync of myenteric and the submucosal, but we see time and time again in our transition zone where we see aganglionosis of the muscle layer and things. So this is abnormal innervation for sure, mostly seen in transition zone. where you see ganglion cells in. What was the first question? Sorry.
So I'll just come again. The first question was, does there exist any procedural guide for the rectal biopsy in patients suspicious of Hirschsprung?
Okay, I think that,
yeah.
There are quite, what I'll do, I'll link a paper. There are a lot of guidance for indication and how to biopsies. I'll be better off linking to this. This gentleman is on YouTube, as you said.
Yeah, no, so he had sent an inbox message in the Google Meet. I think he has left now.
Okay. So I'll probably link it if it says this presentation is going to be on YouTube for long.
He's a member of Path Universe, so we'll share it with him.
Okay, yeah. So I think there are definite guidelines, yeah.
Right.
Okay, so I think that concludes our session. It was a very nice talk by Dr. Shukla, and we thank him for really enchanting and enlightening session on Hirschsprung disease. And so we can conclude here, and a very happy New Year to all in advance.
Thank you.
Absolutely,
Thank you, Dr. Rajeev Shukla and Dr. Tuhin. Before I close this session, let me share with you some things. Dr. Tuhin is an expert in English and Bengali literature. I have no doubts about his pathology knowledge, but his English literature knowledge and Bengali literature knowledge is fascinating. I mean, it's just too good. And before I call it off, Dr. Shukla, as usual, excellent presentation, wonderfully done. My God, tremendous. 150 sections. I'll die seeing them.
Oh no, we also don't like that.
So nice of you to take out time, come all the way to your office to take this class for all of us. It was a really eye-opener for most of us. And as Dr. Tuhin rightly said in the opening, we really have very little experience and exposure to Hirschsprung disease in this part of this country. Thank you so much. I think this is going to be a real good talk for all the postgraduates, FRCPath entries and everybody. God bless you. Good night for everybody in India, and Happy New Year. Thank you so much. Bye-bye. Take care. Bye.
Thank you all.
Thank you. Thank you, sir.